the experts meet. Online learning, practical and sweet. Every Saturday, 9 a.m. Central Time. YouTube, Facebook, X, and LinkedIn. Online.
Hey, good morning, everyone, and welcome to Your Own Nurse. I'm your host, Vic Senese. Nice to have everybody on board today. Hey, do me a favor, like and subscribe. And you guys have been doing a great job. We're almost at 5,000 subscribers, and we just surpassed 2 million views on our YouTube channel. So thanks for all the support. We have a really great show for you today. I've got a great panel of experts with me. And today we're going to talk about something that I think is confusing even to those of us that work in the field. And that's, what do all these initials mean? What's the difference in how the nurses are practicing and how they're educated? So I'm going to bring my panel in here right now and welcome panel to the show.
Thank you.
So I thought what we would do is just kind of one at a time, we'll introduce ourselves and kind of explain what you see scrolling, on the bottom there. And that's what state you're practicing in. Explain all those fancy initials, your scope of practice. And I'm going to do something real quick here, just to show people what the actual Practice Act from Illinois, where I practice, is. And it shows I'm an RN, so I'm not advanced practice, but it shows basically nursing is able to collect, analyze patient data, identify problems and expected outcomes, implement and coordinate care, monitor patient outcomes, delegate tasks, education. That's a big thing that we do. Important limitations: we don't make medical diagnosis, we don't prescribe treatments independently. And on the other side, you can see the advanced practice nurses in Illinois, what they are typically designated as, but they can perform advanced assessments and diagnosis, order and interpret tests, initiate treatments, prescribe medications, provide palliative and end-of-life care, and many can practice independently without a collaborative agreement. And we're going to see what our rest of our group here is doing. I made it big so I could read it, and I lost it. All right, I'm going to get Christy back on the stage here. All right, so as I started to say, I'm a registered nurse. My initials are, as you can see there, RN. That means I passed the boards in Illinois. BSN, that's where my education came in. I went to Rush University. I received actually got a bachelor's in biology at University of Illinois, and then transferred over to Rush for my last 2 years and got a bachelor's in nursing at Rush. And actually the program I'm in now, because so many people do that now is no longer a BSN, it's now an MSN. So they've changed it since I graduated. So they've always had this big push. They want the minimals. What they would like is everybody to have a doctorate in order to practice. So that was Luther Christman, who was the head when I was there, big push. And I work private practice. I worked in the clinic. I'm thankfully retired now. But when I practiced, I had a collaborative agreement with my physicians, which allowed me to do everything outside of doing things like writing prescriptions independently. Wrote plenty of them that they signed off on, but didn't write them independently. So I'm going to turn it over to some of my advanced practice people, and I'm going to bring in Dr. Jeff Albaugh here. So Jeff, why don't you start off with the state you practice in and all that good stuff.
Well, hello, everybody, and thank you for being here. I practice in the state of Illinois, but actually I can practice throughout the VA system, because between Illinois and the VA, with the VA, we had federal supremacy. So whatever state you're in, you can still practice to the full extent of your ability. But in Illinois, I can do that already. I have my particular APRN license is full practice authority. I have no restrictions on what I can do, and I don't have to have a collaborative agreement of any kind or anything like that, either in the VA or within the state of Illinois. And I practiced both in the private sector at Northwestern and North Shore, which is now called Endeavor. I practiced at the VA. So my initials there, my education was, first I went to a diploma program way back when. lived at the hospital. Basically, we all lived there and worked there, and so I did that, the diploma program, and then I went on to get my bachelor's and then my master's, where I did my clinical nurse specialist and then my PhD. So that was kind of how I did my education, and I didn't set out to do all that, but it worked out. And each step of the way, especially on the PhD, I always said, well, I'll keep this semester's good. I'm not sure I'll stay in this program because it's way too much work and too crazy, and they keep changing the finishing line. But I did, and it worked out in the end. I do really like research, and that's part of why that happened. But I loved being a nurse, honestly, and I like being an advanced practice nurse. My other initials, so you see first PhD, that's because I did a research doctorate specifically, a PhD, rather than a clinical doctorate, which you'll probably hear more from the other people about. I did that because I wanted to really focus on different research because I had a million questions in my head. I'm one of those people that always had a lot of questions and wanted answers for that, and have been lucky enough to publish a lot of clinical research. It's been a lot of fun. And then APRN, you see, just says, I am an advanced practice registered nurse. In Illinois, we have to have an RN license, an APRN license, as well as a controlled substance license for each clinic we work in, and a DEA for each clinic that we work in. So those are the controlled substance pieces of it. And then you see CUCNS. So I'm a CNS. I have a basic CNS from ANCC that says I am board certified as a clinical nurse specialist in like adult care. And then through SUNA, I got the certified urology clinical nurse specialist, which I'm very proud of. And because I think it's important when you're specialized to be able to tell people I'm board certified in urology. I think that's a really important thing. And then CSC is, I'm also certified as a sexuality counselor as well. So when you're thinking about all these things and going for all of them, the thing that's complicated is in the state of Illinois, we have to do, I don't know how many hours as an RN, I think it's 20. We have to do 80 hours of continuing education, including 20 hours of pharmacology, 10 of them being on opioid or substance abuse. I mean, it is an inordinate amount, so much work every 2 years to keep all the little pieces. We have to do very specific things, just like the RNs do too, like sexual harassment and Alzheimer's now. And there's all these different things we have to do. Then I have all my certification that I have to do. That's easy to do for urology and stuff. But then as a certified sexuality counselor, I have to do this special ASEC certification. So everything you do, I find I spend almost as much time doing continuing education as I do clinical practice these days. It's challenging. So I would say that I do psychotherapy with a lot of patients because of my counseling thing. And if I went back these days, I would probably have done the psychiatric nurse practitioner route if I had it all to do over, because it makes a lot of sense with what I do, because I deal with mental and physical. Then I can prescribe. I can do psychotherapy. I can do counseling, all that kind of stuff. But so I would say, think a lot about it. I think a lot of people think I want to be an advanced practice nurse. Another thing I want to talk just real quick about is the liability, because I've always had liability insurance. It's expensive. And even though my institutions all give me liability insurance, I always have my own, because remember, when you look at those practice acts, you take on an enormous amount of liability as an advanced practice provider. And so is that what you want? Then I think go for it. I've loved my career. I love being an advanced practice nurse. I love being a nurse. I love being a nurse's assistant. That was an awesome job, washing people's hair and bathing them and talking to them and stuff. But okay, I think that explains the things that you want to Vic.
And actually, I also carried liability insurance the whole time too, just to be safe. All right, Christy, go ahead. You've got the questions.
Sure. Good morning. Thank you for inviting me. It's amazing to be in this chat room with these national and international leaders in our field. I'm really humbled. I think the point that I kind of want to make about credentials is mine change a little bit. based on my audience. So I'll talk about that in just a second. But like Vic, I had a bachelor's in arts and psychology first, then went back to school to get my BSN at a program that was a second degree program very early. So this was in the mid or actually early 1990s when they were kind of just starting these second degree RN programs and BSN programs for folks who had a degree in something else. So you could use a lot of your credits and apply them towards your nursing degree. So that ended up taking me about 2.5 years instead of 4. And then got my master's in nursing to get my nurse practitioner in 2008. But basically, if I'm presenting or speaking or writing for a patient group or a public group, I definitely include my RN credential after my name. Initially, I put my BA in there, but in the clinical and professional setting, that just kind of became irrelevant to my practice.
Yeah.
So again, I sort of changed what acronyms I'm using based on the audience that I'm speaking to. A lot of people don't know what an FNP is. So if it were, again, a patient-facing or public-facing role, I would definitely include the RN. So basically I've got down here MSN, so Master of Science in Nursing, which in the state of Indiana, which is where I practice, you must have a master's degree unless you were grandfathered from before to have a nurse practitioner license. And in reference to practice authority, as Vic and Jeff mentioned, it's different in every state. So in the state of Indiana, you can practice as a nurse practitioner completely independently and autonomously, unless you want to prescribe. So you have to have a collaborative agreement for the purposes of prescriptive authority in the state of Indiana. So like Jeff, I have an RN, I have a nurse practitioner license, RN license separate from nurse practitioner license, separate from CSR, which is controlled substance. So, and yes, continuing education to go along with each of those. So I use MSN, Master of Science in Nursing, for this audience, because you all know a little bit about this already. FNP-C, I'm certified by the AANP. That's where I took my initial licensing exam. And then, of course, I keep that current through continuing education and a payment every 5 years. And then I am also a certified urologic nurse practitioner. I'm actually the current president of the certification board for urologic nurses. And I strongly believe in that credential as a signal to patients and the public and legal authorities that we are suited and specially trained to work in this field, since my training was as a family nurse practitioner. And most of my clinicals were towards sort of a primary care role. So I think the certification really brings an authority and a signal of knowledge and competence, frankly. And then last year I was inducted as a fellow of the FAUNA, fellow of the Academy of Urologic Nurses and Associates, which Dr. Quallich recommended me for that and encouraged me, and I'm really grateful. And so I was inducted into that last year.
Great. All right. Let's bring Susanne in next. You got the questions.
All right. Good morning. So again, I just want to kind of echo everything. Thank you for inviting me. And Jeff, you made me think I never get a chance to talk about how I started out as a certified nursing assistant. No one ever asks me about that. So this is fantastic. So I went from certified nursing assistant to nurse extern, to BSN, MSN, and then way after that, PhD. So I've had kind of the full path as well. I had I never intended to be a nurse per se. I pursued certified nursing assistant because it was a job that I could do over the summer that was always in need. I could always find a job, and it helped me pay for my bachelor's degree. And then realized that I really enjoyed that kind of intimate care for people. And so did a hybrid program. So did BS and then a BSN hybrid program, and then on to the master's degree. So I did have a master's degree that allowed me to certify and practice as a nurse practitioner. I am certified both by AANC and the American Association of Nurse Practitioners as an adult nurse practitioner. So my patient population is really adult people. They classify that currently as about like 16 and older. I practice in the state of Michigan. Go Blue. Here's hoping for basketball today. Michigan is one of the most restrictive states right now. It is not the most restrictive, but it is there. So we have collaborative practice agreements. We can't open our own practices. We're very restricted to how we practice in the state of Michigan officially. Now, having said that, how that actually plays out on an individual facility arena is very, very different. I have been lucky to be paired with surgeons in urology who understand the role of the advanced practice provider, and so have a very, I would say, very free practice. But every year we have those collaborative practice agreements that we re-sign. State of Michigan, just like Jeff mentioned, requires RN license, APRN license, and a DEA license. So we have those three things that we keep up every year, also in the state of Michigan. What else can I say? The certified so I am a certified urology NP. I've been certified since 2000, and really sought that out because I really liked urology. And to Christy's point a little bit, I really liked urology, and I didn't want anyone to take it away from me. And so I thought certification was a really, really good way to let everybody, to let other colleagues, to let stakeholders know that I really liked urology. I was really good at it, and I wanted to stay. And so that was one of the reasons for me pursuing certification. I'm also the CMHE is a certified men's health educator. So my practice really, since I moved to University of Michigan, has been to really focus on men's health and men's urology care. And so that certification I got a couple years ago, and really, again, tells people that I've spent the time and have the experience to focus on really specifically education, men's health, education, men's urology. FAUNA is the fellow of the urology of SUNA, Urology Nurses and Associates. So that's very exciting. I actually spearheaded the task force that developed that credential. So that's exciting. And then I've been a fellow of the American Association of Nurse Practitioners since 2014. And was inducted on my platform, I guess, of really being this person who is pushing both the role of the urology nurse practitioner forward and education in men's health. So again, very just thrilled to be here this morning to talk about that, and honestly to have a chance to think about how far I've come in my own career, and like Jeff, never intended for the PhD. When I was in the master's program, we were constantly getting bombarded with that messaging: do the PhD, and I was like, that's crazy talk. But I went back for the PhD. And Jeff, I don't know if you remember some of the conversations we had when I was early in the program. I was like, this is ridiculous. But really had sort of maxed out what I could do with my master's degree, and was in this kind of unique little niche of this men's urology space where the things I was being asked to do really required a PhD. And so it just became very clear as my career progressed that it was time for me to do that. So cool. Probably never thanked you before today either, Jeff, for those early words of encouragement.
You so earned that PhD, and I know it was really hard, and your studies, your work is amazing. So I'm so glad you did it. Really cool.
Yeah, it feels right. So that's what matters, I think.
All right. So we saved the best for last. Diane, probably the one with the most initials after her name.
Well, it's nice to hear everyone because it's all a little bit different as far as our background, but also all these initials. I started out in 1972 in nursing school at the hospital of the University of Pennsylvania. It's, I think, the oldest nursing school was at that time for a 3-year program. And at that time, the University of Pennsylvania School of Nursing had lost their accreditation. Ooh. And so HUP, as we called it, a School of Nursing, I went there for 3 years. And actually 2 years after that, they closed it. The BSN program got reaccredited, so they closed the 3-year program. It took me a long time to move through all my initials. I went on for my BSN, and I didn't do it. I've been in urology since 76. I did kidney transplants for 10 years. and I was well known in that field. I had published in, during that time I got my BSN, and one of the things I always remember is I had my daughter, and I went to anatomy and physiology class, and my instructor at LaSalle held her the whole time so I could do the class. And I bring up LaSalle because I didn't go back for my BSN for all those years because no program accommodated my working full time and doing it. And LaSalle in the early 80s opened up a weekend BSN program. Wow. And part-time or at night. And I was able to do that. And then it took me many years more. I left kidney transplants, and I actually worked with a urologist who was because I said, Diane, come over to me. And why I left transplants is because the surgeon at that time was upset with me because I wanted to get my master's back at Penn and my NP. And he said, why are you doing that? He didn't want to support me because I was running around all of Eastern Pennsylvania taking out organs. I remember landing in Williamsport, Pennsylvania, and our wheels were flat, and us just landing like that in a plane. So I thought, well, that's not going to work with him. So I left, and this surgeon, this urologist said, Diane, I'm starting an incontinence clinic. Would you come and help me with the women? And I did, and I realized then that a lot of them came back and had incontinence. They didn't have their symptoms resolved. Now, remember, this is 1986. So you guys, I've been practicing for over 50 years. And the thing is that I actually learned about a program down at the GRC, which is a Geriatric Research Center of the NIH in Baltimore. And Kathy Bergio was working with Bernie Engel, who was doing fecal incontinence. And I learned how to do biofeedback. And I actually took that practice, which I put into the urology practice, and I won a monetary award at Penn for that because I wrote it up and said what I had done. So anyways, I did private practice. I had my own business for years with 15 nurse practitioners after I got my MP at Penn in 86. And I sold that practice. And then I went back to Penn in 2000. And I saw Alan Weens sitting giving a talk, and he's talking about behavioral therapy. And I went up to him, I said, you know, Alan, you need someone like me. And it took him 2 years to get me into Penn system because no one could believe I was practicing independently and billing out my services through Medicare, which, if you all remember, in 86, they passed the law that we could go to nursing homes and be directly paid. That's why I started my independent practice. And they couldn't understand them. I had to literally show my receipts for Medicare to say, yes, I'm being paid. So I've been at Penn for many years. So I'm at Penn. I've done a lot of research, and so that's DNP. So let's go with RN I started with. In Pennsylvania, when you get your NP, you get CRNP. It's called Certified Registered Nurse Practitioner. It's a whole other kind of certificate, which is why I use that. And then because of my research, a lot of my fellow researchers, Jean Wyman, Mary Palmer, Kathleen McCormick, Joyce Calling, who recently died, put me up for the FAAN. And that to me is, I think, one of the biggest things I'm proud of. FAAN, at that time, I only had my MSN, but there were very few that got that award, but you had to be put up, and then there was this big committee, and they awarded that to you. So then I thought about doing a PhD. A lot of my nursing research colleagues that I just mentioned told me I didn't need it because of a lot of my work with NIH and that. And I went to Penn School of Nursing, and you guys, they would not accommodate me. They wanted me to end my practice and go full time. And that's something everyone who's listening needs to think about. I mean, they would, and that was at the start of the DNP degrees. They did not have one at Penn at that time. And I thought, I'm not going to do that. I'm not going to give up my career and my practice when I already do research. And a lot of my research colleagues who had their PhD said, Diane, you don't need it. I have to tell you, though, what happened after that. So in 2011, I got my DNP at Thomas Jefferson. And in 2015, I put in a NIH-funded research consortium. Penn did not recognize, they do not recognize the DNP. They do not give nurses anything more for that at the university. I don't know if that's because the School of Nursing is so strong or what, but they do not really recognize the differentiation. But NIH did. And NIH gave me the PI, the sole PI of this grant, of which was over $8 million over 10 years. And I was actually at one point the highest funded NIH researcher in the Department of Surgery at the University of Pennsylvania. I was always the highest in urology.
Wow.
So anyone listening, don't give up your hopes. I mean, I think the PhD for research is probably what I would have really liked long term, but again, nurses don't accommodate other nurses. I really think that's a problem. We don't take people, mentor them, and say, and it's really weird because that period of time I had several nurse researchers in UK tell me, Diane, come, you can do it remotely and we'll give you a PhD. But I decided not to do that. I decided to do NP. So that's that. And then and I got my FAUNA from SUNA. I'm very proud of that because of my like I said, I've been doing urology back to transplants in 1976. But I did the last initials as biofeedback. And I did that, maybe it's been now, I don't know, 12 or 15 years. And I just decided because I do so much biofeedback for pelvic floor dysfunction to get those initials. So that's all those initials.
You got a bunch of them. So it's really great to kind of hear how people, their stories about how they kind of came through nursing. And the one thing I think that really stands out for me is how long we've spent in school. I mean, everybody kind of thinks, nursing is a quick degree. And, there were some 2-year associate degrees. I don't know if they're still in existence anymore, but there's very few people that are practicing with 2-year degrees anymore. It tends to be one of these things you just kind of roll through all the different areas. So I do have some questions that I want to go through here. And let me know, just put up a finger or just start talking. Can you clarify what full practice authority really means for APRNs in the day-to-day clinical settings? So I think some of these may help some of the people out there, but even our other professional colleagues. Anybody want to take that one?
Sure, I can take it. I can actually read it to you from what it means. Is that it means there? So basically, according to the ANP, it means that the state laws are structured in a way that nurse practitioners can basically do everything that they need to do to take care of a patient without needing to check in with a supervising physician, without needing any kind of co-signatures, and can even open their own practices. So the state laws are structured in a way that nurse practitioners can really work to what the lingo typically is to the top of our license and training, so that we are able to fully take care of patients. Now, that doesn't extend to doing things that you would consider very specialized surgery, for example. But it does mean all of the ordering, all of the tests, ordering all of the prescriptions, doing durable medical equipment, doing it extends even to things you might not think about, like exams for disability, exams for Department of Motor Vehicles, disability exams. Sometimes there's some states where we can sign off on death certificates. So there's a lot of nuances to that sometimes folks don't think about, but it makes us really like fully rounded, fully capable providers.
Yeah, I think that summarizes it pretty good, Susanne. But one other thing is, so then things like, I don't do these things specifically, but my colleagues, some of them do, is like the cystoscopy things, the biopsies, the things that are a little more advanced procedures that you can do those things with full practice authority. And certainly, though, like you said, not surgeries and specialized things like that, but some of those procedures can be done as well. You're not restricted on that, which is really good. And you don't have any collaborative agreements or any other kind of thing, which is kind of nice. And it may vary still with certain things that go on from state to state or across the country. But I know that we do have, with that full practice authority, you're supposed to be able to practice to the full scope of your ability. I think, too, another thing it reminds me of is I really am proud that I'm a nurse, and although people call me doctor in my practice all the time, it's very important. I know in our state, I don't know about other states, that we let people, that we distinguish the kind of doctor we are, because there's psychologists and there's us and there's MDs. And I always make sure patients know I am not a medical doctor. And I love my medical doctor colleagues, but I did not go to school to do that because I love the nursing paradigm, which is about education and advocacy. And I am first and foremost always a nurse. That's what I became. That's what worked out for me in my trajectory and practice. So I think that's really important. And I like people to know, I just spent, my intake is an hour long. I just spent an hour with you. That's a wonderful luxury I get as an advanced practice nurse to do with you. And so it's really a great thing to be able to focus on education and advocacy and mental health and all the different things that I get to do as a nurse with that different paradigm. But yeah.
Well, when you talk about, there's actually over 30 states now that have independent practice where we can practice independently. When you look at the map of the U.S. and its U.S. and territories, the West is more independent. I didn't talk about Pennsylvania, but we were very restricted in Pennsylvania. And what you see happening, and I don't know if this is going to change, although in Pennsylvania we have so many rural counties that need NPs and PAs. We need to be more independent, but what happens is the Board of Medicine blocks all the time when we try to, pass the independent. And I think that'll change. But where you have more practicing MDs, you find we're more restricted in practice. And if you go west of maybe Illinois, you see all this green of where they are practicing independently. And I think the future for nurse practitioners, advanced practice providers is independence. I think that's where we're going. I mean, there's a lot of research. One of the reasons why in '86 Medicare allowed NPs to directly bill for their services seeing nursing home residents was because there was research showing that we cost Medicare less money. We did less prescribing. We had less readmissions to hospitals from nursing homes. If the resident was handled by nurse practitioners, we had less procedures that we were prescribing. So, if you look at the data of advanced practice providers, including PAs and NPs, we tend to be a lower cost to the healthcare system. And I agree with everyone here. Look at the number of years we have in education. To say that we're not capable of what our practice is, I think is just a fallacy. I think it goes back to business, right, and territory. But I do think that the goal will be more independent practice for us.
Yeah, I've seen a real shift to that. I think in recent years, especially with probably the lack of enough urologists being put through in the practice, that they are relying now on having nurse practitioners in their organization because they can't see the patients. They want to just do the surgery and they want the nurse practitioners to take care of the rest. Probably not for a bad thing either. Jeff, you had something?
Yeah, well, yeah, because that's why I say like even in the practice that I created, an endeavor that we had built up from the floor down with sexuality clinic was our intakes are an hour. We are doing the things that our urology physician colleagues don't want to do. We're here to see you. We're the right provider to provide what you need in terms of education advocacy. But I think it's so crazy, Diane, about the PhD thing and that's why as nurses, we need to support each other. We need to support. I worked full time while I did my PhD. I think Susanne, you did similar with yours. And the reason being is all my research was based in my clinic. So how do you do your research when you walk in your clinic?
Exactly.
That's insane. So I do think it's really important for us to support nurses. Sometimes we just don't always do the best by ourselves.
Yeah, well, it is a shame. Like the first year that I was in the PhD program, I took a lot of, we can call it verbal abuse because that's really what it was, because I was not full time, and my dedication to the program was constantly questioned. My, my dedication to life was constantly questioned by the advisor that I had at the time because I was not full time, and I am an adult NP. My credential doesn't even exist anymore. So if I don't have enough clinical hours to renew my certification, I actually have to go back to school to become recertified as an adult Gero NP. And so finally I said to them, I need to keep working so I don't lose my NP credential. Oh, and by the way, I'm also precepting your students. So if I don't, so I'm precepting students while I'm doing the PhD program. And I said, you lose a preceptor, like all of this conversation, if you want me to go full time, means that you lose a preceptor. I run the risk of losing my adult NP credential, and I'm not, that's ridiculous. So I eventually got a different advisor. But again, to all of the points, it goes to show, it's like Diane, I totally feel you about the flexibility. Our programs, 2 years after I was admitted, changed to the PhD where it's full-time or nothing. And I thought, this is a shame because you lose good people who have all of that clinical experience. So I totally feel your story. And it's ridiculous,
Well, and you know what, my story at that time too, I was divorced with a 14-month-old child. And, there's a lot of, Jeff and Vic, I know you're not women, but there's a lot of women in nursing, and we do not accommodate mothers. And, that was one of my biggest issues. I mean, I just couldn't quit and just say, oh, well, I'm just going to go and do X, right? And that's why the LaSalle program, when it came up, I could do it as a part-time. I was like, wow, because I always want to go back to Penn, having come out of the 3-year program there. But they were so non-accommodating. And I hate to say it, I think nurses do not mentor well. I think that education do not. I remember a big argument when I went with my MSN. None of my instructors had a clinical practice. You know what I mean? And here I was going for my MSN, and I actually am an adult nurse practitioner. That was what it was back then. And I felt such a disconnect. You know what I mean? They hadn't practiced in years. They taught. I mean, they were very well qualified PhD. They may have been some research on clinical, but they didn't have clinical practice. So I think that's, there's some innate issues within nursing as we move on that still are not solved. And I think that's a major problem.
I have a question I'm bringing up here next. How do hospitals' privilege and credential processes differ for APRNs compared to physicians? Are you guys credentialed to work at hospitals? I know I was a urology nurse clinician. I had to be credentialed to work at the hospital that we were part of because I saw patients in the hospital. So let's hear what others are saying.
Yeah, so actually I wrote about this recently. They don't. Provider is a provider is a provider. The credentialing is the same. You have to go before the credentialing committee. So you get credentialed, and it's important. There's a distinction in there. Like, you get credentialed, which means you're okay. Like, they allow you to take care of patients on their site, but then you are privileged to do specific things. So you are privileged to do, for example, in urology, we are privileged to do scrotal incision and drainage. We are privileged to fit pessaries. We are privileged to do Xiaflex injections. We are privileged to change and start suprapubic catheters. So the credentialing just means you're okay to work there. The privileging is the piece where that details what you can actually do with patients, for patients, in your role. And it's a very important distinction. And so you have to have both pieces in place before you can actually effectively work on site and then bill for your services.
Susanne, can I ask a question about that? So, I mean, I've never seen the privileging forms that the physicians fill out, right? But I know that for privileging, for me as an NP, it was a long list, under each specialty of the types of things that you could do. So I'm curious from the physician side, what is their privileging form look like? I imagine it's more surgical skills and that they wouldn't necessarily have to be privileged to place a catheter, but what does the physician privileging look like?
It's a great question. I've never actually seen the physician privileging form, but when they go to add different things, like I know our surgeons who do the urodynamics always have to have the additional radiology privileging. Our physicians who use the laser have an additional privileging for the laser and the OR. Yeah. So there are some nuances, but I suspect that it's not as spelled out. I think it's a more global form than what we are used to, because remember, we're all trained as generalists. And so when we move into these specialty areas, we need to be privileged to do nerve blocks in neurosurgery or to do cervical biopsies in women's health or OB-GYN. So our stuff tends to be a little bit it needs to be spelled out, because many of those things that we end up being privileged for, like cystoscopy or prostate biopsy, like Jeff mentioned earlier, are not part of our original training. And so there's additional checks and balances to make sure that we're trained and knowledgeable in doing those things
appropriately.
Look at your privileges, because I had to make sure, because I was trained in couple therapy through Gottman and IBCT, and I'm trained as a sexuality counselor, and I do psychotherapy. So all that is in my privileges, in addition to the standard privileges that they get advanced practitioners. So look at that, because that really does speak to what you're able to do in your practice.
Yeah. And you never want to be doing something that you were not privileged for. Even if somebody told you that, oh, it's okay, Jeff, you can go ahead and do that cysto. If you're not privileged for it, you do not want to be doing that. No matter how encouraging and flattering they are, you just want to make sure that's part of your privileges.
Yeah. All right. I have another question here. What does the evidence show about patient outcomes when care is delivered by APRNs versus physicians? Diane, I'm sure you've got something to say about that.
Yeah, like I said, that the data is out there, especially with the Medicare population, as far as we cost the health system less. And there's a lot of, the nursing home data shows that, and that's why you see so many more APRNs in geriatrics and really managing those individuals. There's enough research out there that, people have done. Harvard's done a lot of publications on the fact that we really do cost less. I mean, there's no question about it, in the sense that we don't prescribe as many testing. We have less readmission rates of patients that we manage. So I think it goes back to, I think, Jeff, you were saying, is how you like the fact that you want to be a nurse because it's different than a physician. I mean, I get asked that all the time. Diane, you should have went to be a physician. I'm like, no, I don't want to. That was never my interest. I think that I like what I do holistically, and I've been able to achieve most of my goals. But the thing is that when we look at, cost savings, I mean, it's out there. And that's why we see insurers allowing independent billing. And that's why you've seen that growth in independent practice in a lot of states. Because I think we're really an integral part of the health system. But also I think that I say all this, but I recently had a discussion with someone I brought into Penn and in urology years ago. She's a fantastic individual, Christy B. And we were discussing and debating the bonus system we have at Penn for APPs, just not APRNs. And I kept saying to her, but what happens if you do urodynamics, where you're only maybe doing 5 to 6 a day, because the bonus system is based on numbers? What happens if people call out sick or don't show up and you have to hit a certain number that day? And, we went back and forth on that. And because she's more in an advisory role now within surgery, we're becoming more, we're being tracked more at the physician type of productivity. And I say that because of the fact that we recently got down to, you only do 15 minutes, and I have huge arguments because I can't do an evaluation, especially pelvic exam, and do what I want to do in 15 minutes. Yeah. I recently spent a day up at Geisinger, which is in the middle of the state. They own so many health systems in the middle of Pennsylvania, in the northern part. And that chair of urology, I just wanted to kiss him. He is so pro APPs. They were doing a cysto course and a truss course, and he was involved. And he stood there with like 18 of his APPs saying, "We want you to learn this. If you're getting negative feedback from my other colleagues, I want you to tell me." He was just so for, and he told me that he gives them 30 minutes to see a patient. I was like, oh my God. I haven't seen 30 minutes in my practice for years. Mm-hmm. And, I don't know if it's going to change, you guys, as far as us being a less expensive healthcare provider within healthcare, because of the fact that I feel we're moving more towards the metrics that physicians have to meet.
Well,
the numbers of people you see.
Yeah, 100% agree. But the one, just to refer back to the question, is that we don't have outcomes data for APPs in urology. So we do in these more, you're exactly right, Diane, in these these Medicare, these primary care domains, we don't have any of that data for APPs in urology. And that's been one of the things that I've been, trying to bring to the AANP's attention, is that you're not just unique to urology, but in particular to some of these aesthetic practices that are popping up, is there's no outcome data, and we also don't have literature to refer to. There's no evidence base for how we are actually being trained to do these procedures across specialties, and it's I worry sometimes that it's going to end up being a real problem at some point, because somebody's going to be a test case for this. Now, having said that, I know we all know that there's urology fellowships out there, but if you look around, they don't publish their data. They don't publish their training. They don't get down to some of that granular level. I don't want this to be misconstrued as I don't think we can do these things. Obviously we can. Obviously we are doing them. Presumably they're being very safe. But we just don't have to answer that question like directly. Like, we don't have data for how we are performing as APPs, APRNs in urology.
But there's Vic, you got to do a talk. You got to do one of your Zooms on this. There's a fantastic publication by Hooker from 2024, and I recorded this for Grand Rounds Urology, where they show from 2000 to 2024 procedures performed by advanced practice providers and physicians in urology. And all you see, there's 3 graphs there that are just fantastic. And all you see is our procedures like this and urologists like this. So I really think that's the impetus behind us. Do more, do more, do more. And there's another publication that was done in a men's health clinic where they showed the revenue generated by a nurse practitioner who ran this clinic, over a 6-month period. So you're seeing the fact that we are doing more procedures. Urologists, because of the numbers, are doing less. But I don't think that, like what you said, Susanne, we're really coming out and pushing that, right? That we are doing more. Why aren't we, compensated maybe better, or I don't know, whatever, why are we not listened to more? But there's no question that our volume is going up. The other sad thing about all that, there's data out there now showing the burnout of APPs in urology is actually almost like 30% after a couple of years. And I see this all the time with a lot of my colleagues going into industry, right? Becoming medical liaisons in industry because they're burned out from practice. So I hate to say it, I feel like some of what's happening is similar to what's happening with physicians, but I don't think we're getting the credit in urology for what we're producing.
I think too, like you were asking about patient satisfaction. So I'd like to speak to that a little, because there is a lot of data out there about patient satisfaction with APRNs versus physicians. And studies indicate equal to higher satisfaction. And even in specialties, this is more vascular. This study in particular, they showed satisfaction went from about 94.7 to 98.9% with the APRN versus a physician. So you see equal to better satisfaction when you see patient satisfaction things. But this is interesting. Preference, you still see that sometimes they would say they would prefer their physician colleagues. So that puts the onus on us. Are we doing our job? Does the patient think they're seeing us because the doctor doesn't have time or space in their clinic and they're too busy and just want someone else to see them? Are they seeing us because they need education, advocacy, and what we offer that's a little different than what they do? I make sure my patients know this is why you're seeing me. This is my specialty, and this is why I spend this time with you, because I'm educated in the health side. And so I think it's on us to make sure that they don't see us as a substitute, but rather the right person to see for their particular problem, like pelvic floor rehab or incontinence or sexual dysfunction.
Yeah, Jeff, I'm glad you brought that up. And I was thinking the same thing. There's so many different metrics to look at in terms of how we stack up, right? And I think patient satisfaction in my department at Indiana, it was clear that the NPs were right up there with the docs. And that has changed. Obviously patient willingness and acceptance of seeing an NP or a PA has changed, right? When I first went into practice, I was the first in our department, and patients were like, I'm sorry, see a what? Like, no, I want to see the doctor, so I really had trouble kind of getting started in the outpatient setting. But as things went along and, in the Midwest, APPs became more commonly seen in clinical practice, lots of patients, of course, say they prefer, anecdotally at least, prefer to see an NP because of those things Jeff just mentioned. Focus on education, comprehensive understanding, time that we can spend for now until we get up there, like Diane was saying, with the same time slot expectations and things like that. But yeah, I think patient satisfaction is much more nebulous than the bottom line, but extremely important.
I think it's a good point that we bring out is we have to sell ourselves too.
Yeah.
We're really good at what we do, but sometimes people don't know that. I think as they start to learn more, as you say, they're getting exposed to nurse practitioners more. They're starting to realize there is a difference between what physicians are offering and what the nurse practitioner is offering. And often it's that educational piece. It's that listening piece where you actually take time and spend time with the patient. I mean, I think that's really key. Well, this has been a great discussion. I think I'm going to want to put a panel together again in the future to talk, because this has just been fantastic, bringing everybody's perspective, not only just different levels of education practices, but we practice in different areas of the country, find out that things are done a little different depending on where you practice. So next week, I'm going to be talking about
varicocele are one of the most common and often overlooked causes of male infertility, low testosterone, and chronic scrotal discomfort. In this episode of EuroNurse, Vic Senese breaks down everything you need to know about varicocele diagnosis and treatment. Learn how varicoceles develop, why they're so common, and how they can impact fertility, sperm quality, and hormone levels. Vic walks you through the diagnostic process, including physical exams and ultrasound imaging. Join us on April 11th at 9 a.m. Central Time to learn more.
Yeah, so be sure to join us next week to learn more about varicocele. I'm surprised. I was looking through my things that I've talked about over the past 3 years in EuroNurse. Never had anything on varicoceles. I think it's something that shouldn't be skipped. So we'll be doing that next week. Any last words anybody has before we go off the show? All right. Thanks a lot for joining me this on this great day of discussion. And we'll see everybody hopefully next week.
So here's to the mornings, the coffee, the monitor glow, to the wisdom he shares and the folks that he knows. Saturday is special when Vic's on the stream with 40 years of knowledge and a head full of dreams.